Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place where I get to spoon feed you guys the latest and greatest of emergency medicine. Now, if you are hearing this right now, then you are not currently a Journal Feed subscriber and so will not be receiving the full Journal Feed podcast. If you would like to get full access to the podcast and the blog, then you'll have to become a member. All the details for that are at our website, journalfeed.org. Now, this is the audio version of the past week summaries, which this week were brought to you by our authors, Michael Stoker, Aaron Lacey, Samuel Rouleau, Caitlin Nicholson, Doug Wallace, and Clay Smith. Okay, let's skip straight to the third article, titled Intubation Setting and Mortality in Trauma Patients Undergoing Hemorrhage Control Surgery, a Propensity Score Matched Analysis, out of the journal Anesthesia and Analgesia. You might recall that a few years ago, I think it was, we covered an article that said that if you intubate a patient who is the victim of trauma in the emergency department, then they have a higher odds of mortality. Is this because of intubation in the emergency department, or is this because they had to be intubated in the emergency department, so they're probably sicker? It's been a little bit hard to tease this out. People have tried to control for as many things as they can, and it still seems to be that most of the signal goes towards intubating in the emergency department is not a great idea for these patients. This could be due to a number of things. Probably principal among them is that we try to go for a CAB approach in trauma, circulation first to get the blood back into those patients and stop them from bleeding. Whereas if you're doing an ABC, then you're going to intubate a patient who's probably more unstable, hasn't been resuscitated as much as possible, and thus you might not have the best outcomes. Now, these authors wanted to take a look to see if that was the case in their center. They looked at adult patients aged 18 to 65 years old who required trauma surgery for hemorrhage control or intracranial injury within 1 hour of arrival to the emergency department. They had nearly 1,000 patients, most of which were male, which is typical. About a third of the patients were motor vehicle accidents, another third were gunshot wounds, and the rest were just a spattering of other things. 470 patients were intubated in the emergency department, and these patients tended to be sicker, a higher injury severity score, higher rates of shock, and higher rates of head injury. However, when you control for all the things that you possibly can, including those 3 things I just mentioned, in 1-to-1 propensity matching, using 271 of the patients who were intubated in the emerge versus intubated in the OR, then they showed that there was a similar mortality between these two groups, about 12% on either side, and so there was not a significant association between being intubated in the emergency department compared to the OR. However, there was an association with being admitted to the ICU if you were admitted in the emergency department. Now, I think that this is kind of just one study among several, and so it's not going to move the needle per se, but it's interesting to see some data come out on the other side of this, and it's definitely something to think about. I think the general advice is probably that if you don't need to intubate them in the emergency department, then you probably shouldn't, and you should resuscitate them as much as possible. But of course, don't delay getting them to definitive care. In a spoonful, this trauma registry study from Israel, which I didn't mention before, did not find an association between emergency department intubations and mortality after propensity score matching. This is different from several other studies on this, and so it might be unique to this study population and the practices in this region. And then the fourth article, titled Association of Cannabis Use with Cardiovascular Outcomes Among U.S. Adults, out of the Journal of the American Heart Association. Now, we have a lot of different drugs that people can do, and a lot of them are not very good for your heart. If you drink a lot of alcohol, that is not good for your cardiovascular system. Of course, if you do cocaine, we know that that is definitely not good for your cardiovascular system. But what about cannabis? Cannabis use has been increasing in the United States, even surpassing alcohol in some studies. So if we're having more and more cannabis use, and this is going to replace alcohol, is this going to be better for people's hearts? THC has been reported to have some hemodynamic effects, including syncope, stroke, and even MI. And smoking, really anything, just really can't be good for you. This study was a very large survey study on 434,000 people from the United States, the Behavioral Risk Factors Surveillance System database. I know it's survey data, but I mean, if it's the best we can get, then it's the best that we've got. So take it all with a grain of salt because these are self-reported things by patients, but they have no real reason to hide stuff, although people don't tend to be very honest about their drug and cannabis use and stuff like that. So we saw that from this study that the use of daily cannabis in the United States was nearly equal to that of alcohol, and so it really is being used quite a bit these days. Then, after multivariate logistic regression, it was shown that daily cannabis use was associated with myocardial infarction, stroke, and some composite outcomes, none of which are good for your heart. The association remained significant even among never smokers, that's of tobacco and other things, and individuals who had a high risk of premature cardiovascular disease. About a 25% increase in your odds of MI if you're a daily cannabis user, that's really no joke. However, there was not a significant association with congestive heart disease, for whatever reason. Now, I will admit that I do not ask very much about risk factors in the emergency department. It's very hard to apply that kind of population data onto an individual. Of course, I do ask about cocaine and things like that, and it's not that it means nothing, it's just hard to really pin onto someone. So you smoke some cannabis, so you smoke some cigarettes. It's not really going to change my decision-making all that much. Of course, yes, it is a risk factor, but you'll notice it rarely makes its way into some of our decision tools because it's not that big a risk factor for the emergency department. Though these patients certainly need counseling for a better, healthier lifestyle, because it will help them in the long run. That being said, I'm very interested to see that daily cannabis use was associated with some pretty hard-hitter outcomes. In a spoonful, don't smoke. Anything, really, but in this case, cannabis, and your heart will probably thank you. All right, that's it. That's all the articles. Let's wrap up quickly what we learned today. Then from the third article, this study seemed to show that intubation in the emergency department instead of in the OR for trauma patients, it was not associated with greater mortality, which kind of goes against some of the other literature on this topic. Then from the fourth article, cannabis isn't harmless. It's actually associated with an increase in MIs and strokes. Again, if you were hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What are those articles about? Well, should helicopter EMS decompress with a finger pre-hospital? What's the word on ketamine and post-intubation hypotension? And then how does a chest x-ray really do at ruling out pneumonia in children? Links to all the original articles can be found at thejournalfeed.org or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.